And we'll move on to the next speaker, who is Professor Stephen Harrison, who is a renowned expert in treating NASH and who has been a leader in many trials in NASH. Professor Harrison from University of Oxford and also Summit and Pinnacle in San Antonio. He's gonna talk to us that the trials and the treatment and the future looks bright. Please go ahead, Stephen.
Yeah, hey, thanks, Matthew. I appreciate that. It's great to be here today and to share some data on where we're headed. It was great to hear the previous speaker talk about current approaches to management, and I agree with those comments. So let me jump right in. I think let me say this at the beginning. 2022 was a pivotal year in the field of fatty liver disease. Where we were at the beginning to where we are now, a significant amount of progress has been made. And I'm looking forward to 2023 because I think we are at a pivotal time now in the field and are on the forefront of some amazing opportunities to help our patients. So first of all, I want to focus on diagnosis and kind of where we are currently. I didn't spend a lot of time on epidemiology. I thought that would, be something that would be addressed in other sessions. But when we focus on diagnosis, what we've learned is we want to combine demographic information with imaging information and laboratory data, because that gives us our best shot at enriching for the diagnosis of NASH with advanced fibrosis. And so before we go any further, I think it's important to know why we're looking for these particular patients. And there have been multiple different studies now around the world that have shown that NASH with F2 or greater fibrosis portends a worse prognosis. And so that for that reason, the clinical trials are enrolling this particular type of patient. And so if we can surmise that this is what's being put into clinical trials, then on the back end, when we have drugs that are approved to treat this disease, well, they're going to be approved in the types of patients for which they were studied. And that would be this particular group of patients, those with NASH and F2 or greater fibrosis. We've also learned quite a bit in the field about the utilization of metabolic syndrome risk factors in combination with specific serum test and imaging test. And we know that sequential use of these tests increase the area under the receiver operator characteristic curve for making a more accurate and precise diagnosis. We usually have two cutoffs, a lower cutoff and an upper cutoff. The lower cutoff optimizes sensitivity, the upper cutoff optimizes specificity. And as you combine these tests sequentially, the indeterminate zone shrinks. So that's where we get a more precise and accurate diagnosis. So we have several non-invasive strategies in our armamentarium today. We have blood and serological based simple scores. You see those listed here, ALT, AST, and the AST-ALT ratio. I use that more than anything else. The ratio of AST to ALT, when it is close to 1, sets it apart as a biomarker. Now, the caveat to that is they have to be abnormal, because in the setting of normal ALT and AST, that ratio doesn't have any prognostic capability. But when both are abnormal and they're close to 1, that is highly suggestive of advanced liver disease. Now, lots of data have been published on FIB-4 NAFLD fibrosis score, and more recent data coming out with PRO-C3 as a marker of fibrogenesis. This is not readily available. It's not commercially available. but you'll often see it in NASH clinical trial drug development as a biomarker of fibrogenesis. Now, there are certain proprietary predictive scores that are out there. There's liver fast, there's NASH-4, and there's ELF. So just to highlight on a couple of these, the ELF test is approved in the United States for use as a prognostic biomarker. It is commercially available in the US. I'm not sure about the Asian PAC region. NASH-4 is not currently commercially available. This was a combination of 4 different biomarkers that we put together from the Resolve It data set from GenFit and their very large phase 2B and phase 3 program. More recently, that test has undergone a revision, and it was originally presented at AASLD in the fall. Now NASH-2, so specifically just combining YKL-40 with MIR34A. It gives us the same predictive capability as NASH-4. It's focused on that at-risk population of patients, NASH with F2 or greater fibrosis. And then there's imaging tests, the ever-present FibroScan or vibration-controlled transient elastography, the gold standard for fat quantification, MRI proton density fat fraction, a newer but more potentially a better test for fibrosis. Some would argue the gold standard for fibrosis, MR elastography, and then multi-parametric MRI or corrected T1, helping us with inflammatory change or activity within the liver. And very often in our clinical practice, we will combine all of these tests, FibroScan, MRI-PDFF, MRE, and CT1, in combination with some of the serological or wet biomarkers you see to the left. Now, just to highlight a couple of these, starting with the wet biomarkers, you see the NAFLD fibrosis score on the left with its component parts highlighted in the center, and then FIB4 on the right, highlighting that it is very simple to do. It combines age, AST, ALT, and platelet count. There is an online calculator that you can use if you just type in FIB4 calculator. And as with any test I previously mentioned, we're getting a low cutoff with a high specificity and a high sensitivity, and a high cutoff which optimizes specificity. And then there's this indeterminate zone in the center that still needs to be further evaluated. When we look at some of the predictive capability of these tests, I highlight one of these here. This is FIB4, and work done by Quentin Anstey's group out of Newcastle in the UK, looking at about 45,000 individuals. This study period was over 20 years, from 01 to 2020, and the endpoints looked at were time to first liver event, cardiovascular event, and death. And as you can see, if you break that FIB4 down into its high component, which is greater than 2.67, and low component, which is less than 1.3, everything else in the middle is indeterminate. You can see that regardless of which endpoint you're looking at, that a high FIB4 actually stands out at predicting outcomes relative to a low FIB4, or in some cases, even an indeterminate FIB4. This is very provocative data, because I do think as we transition from liver biopsy to non-invasive test, this type of data becomes very helpful in changing the paradigm with the regulatory authorities. So just a snapshot of where we're headed there. Now, when we look at vibration-controlled transient elastography, what we've come to learn, at least in Western populations, is that a score less than 8 has a high negative predictive value in excluding advanced fibrosis. Now, why is that important? Well, that number is actually what is being used in some of the guidance documents that are coming out now for screening populations at risk. So what we're seeing, whether it's the European Association for the Study of Liver Disease guidance, or AASLD practice guidance, or the AGA guidance, or the ACE guidance from endocrinology, all starting with FIB4 as a screen, and then looking at vibration-controlled transient elastography as the second sequential test, and that cutoff of less than 8 is what's being utilized. So again, highlighting the fact that you want to combine these non-invasive tests sequentially to suppress or decrease or minimize that indeterminate zone. And I just highlight very briefly here, this is the AGA guidance that was published in Gastroenterology about a year and a half ago now, focusing on risk factors first. If you're a diabetic, if you have 2 or more risk factors, if you have steatosis on imaging or elevated liver chemistry tests, go ahead and get some basic lab work and really try to hone in on alcohol ingestion. There's no comment here about measuring for PEth testing or other specific tests for alcohol outside of a history. But if you have that capability, you might consider it. It's something that we're looking at in the clinical trial field. Now, in step 3, go ahead and get the non-invasive test, the FIB4 in this particular case. And if it's indeterminate, follow that up with a FibroScan. If it's less than 8, as previously mentioned, you're good to go. Now, this is the EASL guidance, really very, very similar here. The only difference being that there is optionality for doing additional testing versus going on to liver biopsy. And then I wanted to move quickly into treatment, just to highlight, in the absence of FDA-approved therapy, as was mentioned already, we need a patient-centered approach. We want to tackle the overweight or obese subjects. As was previously mentioned, I agree that is a major factor here. I would also argue that diabetes is also very, very significant, a little bit challenging to know what comes first as far as severity of comorbidity, obesity, or diabetes, but suffice it to say, they're both very important to manage. There is a recent paper published, and I have it listed here, in Nature Medicine, published this year by Master and colleagues, looking at Fitbit and step count, showing that more than 8,200 steps taken per day actually protect from incident diseases such as obesity, reflux, major depressive disorder, and there it is, diabetes as well. So it's not that we have to get our heart rate up to a certain point to achieve a certain metabolic equivalent rate. It's not the amount of time. It's really focused on just movement. Can we work to the point where we can get our patients to walk around 4 miles per day? There's been some more recent data here from the NHANES database suggesting that patients that walk 8,000 steps or more per day compared to those that walk 4,000 steps a day actually reduce their overall morbidity and mortality by 50%. So managing these cofactors, dietary modifiers, and then treating comorbidities, already heard some great discussions on that. So when we look at the regulatory framework for drug approval, we have what's called surrogate histopathologic endpoints to achieve conditional approval. This means that you can market your drug, you can sell your drug, you can provide your drug if you achieve these 2 either or particular endpoints: NASH resolution without worsening of fibrosis, or fibrosis improvement without worsening of NASH. Now, you're not done. Just because you achieve this, that gets you conditional approval. Remember, that's a surrogate endpoint for having a reasonable likelihood for providing clinical benefit to our patient. But we still have to go on and do the longer term study to show we actually are impacting how patients feel, function, or survive. So this just is kind of the halfway point, but it does allow us to provide a druggable pathway for this particular liver disease. So where are we at in the phase 3 trials? Well, there are 5 drugs that have made it to phase 3. The first one listed here is on hold and is not currently enrolling in phase 3. The second one, resmetirom, is a thyroid hormone receptor beta agonist, and it actually is in phase 3. In fact, the Maestro-NAFLD-1 trial, which is a non-invasive trial focused on safety and tolerability and looking at non-invasive tests, has actually reported out already, showing that the drug is very safe and well tolerated and is given once a day at either 80 milligrams or 100 milligrams per day. The registration trial, or the regulatory endpoint trial that addresses what I just mentioned as far as biopsy change, is imminent. We expect that to be reported in this quarter of this year, and there are not many days left. So stay tuned and buckle your seatbelt for that. Obeticholic acid is already reported out. It reported out its phase 3 trial a couple of years ago, and it showed some positive results. We'll go into those in a moment. Unfortunately, the FDA did not approve that drug. They didn't give up. They've persevered. They have a new methodology now for interpreting the results, showed very, very similar results on fibrosis benefit, but much, much more safety data. And I think they plan to file their new drug application again before the end of this year, which is coming up very quickly. So the last two drugs, semaglutide, a GLP-1 receptor agonist, and lanifibranor, a pan-PPAR agonist, are both enrolling their phase 3s currently. So just a little deeper dive in some of these medications. The first one, obeticholic acid, it's an FXR agonist, which has been shown in clinical trials to have positive impacts on inflammation, fibrosis, free fatty acid flux, and lipotoxicity. And it works by blocking CYP7A1, which is the rate-limiting enzyme that converts bile acids to cholesterol. So looking at the Lancet publication from a couple years back on the primary endpoint by intention to treat, we see there was about an 11% treatment effect delta with the high dose 25 milligram versus placebo on fibrosis improvement of at least one stage without worsening of NASH. And on NASH resolution, it did not achieve statistical significance. When we look at the GLP-1 receptor agonist, semaglutide, that we know as being utilized broadly around the world for obesity and for type 2 diabetes. So how does it work? Well, this GLP-1 receptor agonist functions by in the brain to create a sense of satiety. It slows gastric emptying, it increases insulin secretion in the pancreas, and it reduces glucagon secretion from the liver. All told, in clinical trials, this has been shown to induce weight loss, improve liver chemistry tests, reduce liver fat, and have a beneficial impact on NASH resolution, as well as prevention of progression of fibrosis, but no specific action on reduction of fibrosis to date. And this is the phase 2b trial published in a New England Journal of Medicine about a year and a half ago, showing a very positive impact on NASH resolution, particularly with the high dose. We see a very striking odds ratio and a p-value that is less than 0.05. Unfortunately, on the right, we do not see the same for fibrosis benefit. How about lanifibranor? It's a pan-PPAR agonist. That means it's working on PPAR alpha, PPAR delta, and PPAR gamma. And from the phase 2, we see that there are positive impacts on not only reduction in this, the SAF activity score. We see statistical significance here in a stepwise fashion, dose response manner, but also on a secondary endpoint of improvement of fibrosis without worsening of NASH, and also resolution of NASH without worsening of fibrosis, all with only 24 weeks of therapy. Now, from a safety and tolerability perspective, there was a concern with weight gain at the high dose group. And remember, that's probably the PPAR gamma impact. Further, the phase 3 trial is now ongoing. There's 72 weeks of treatment there, so it's 3 times longer treatment. We'll have to see what happens with that weight gain and follow that very closely moving forward. Now, let's talk about resmetirom. It's a thyroid hormone receptor beta agonist. This plays a central role in liver function. It impacts a range of health parameters from serum cholesterol and triglycerides to the buildup of fat in the liver. Think of the liver as being relatively hypothyroid. It cannot convert the inactive T4 to its active component T3. So you get a buildup of reverse T3 that actually is associated with worsening of liver inflammation. So by modulating the thyroid hormone receptor beta specific receptor, we can improve many of these factors. In fact, you see some of these listed here. And when we look at the phase 2 trial, which was published in the Lancet a couple years ago, we see that it has a major impact on liver fat content reduction as measured by MRI-PDFF. In fact, you see here, placebo is in blue, around a 10 to 14% reduction looking at week 12 and week 36. The primary endpoint, incidentally, being liver fat content reduction at week 12, despite this being a 36-week trial. And you see when you combine all doses, week 36, around 40% liver fat content reduction. And if you look at 80 versus 100, we see 50% liver fat content reduction with the 80 milligram dose and 64% with the high dose. Suffice it to say that the 80 and the 100 was what was carried forward into the phase 3 trial. There were also key secondary endpoints on improvement of NASH resolution and improvement in certain specific biomarkers of fibrosis, liver chemistry test, and atherogenic lipids. So moving forward to the phase 3 NAFLD-1 trial that I commented on a few minutes ago that has already been reported out. It has not been published yet in peer-reviewed literature, but I highlight the presentation I gave on this at EASL this past year in London, focusing on some of these non-invasive tests such as MR elastography and FibroScan. And I wanted to show you here, when you allow for the coefficient of variance of these particular imaging modalities, you see a stepwise improvement of both doses of drug over placebo, whether you look at FibroScan or you look at MR elastography. So very encouraging news here. Now, when we think about resmetirom, and I highlighted before that we are expecting from comments made by Madrigal that we should hear on the top line results from the Maestro NASH trial before the end of this year. What does that mean? What do we expect in case of positive results? There is a process to file the regulatory submission, and that generally for studies of this magnitude takes about 6 months to pull all that data together. And then it gets filed, and then because there's a fast track approval process for resmetirom, the regulatory authorities, in this particular case, the FDA, has about 6 months to review. And so once it's reviewed, then of course they'll report their findings, and then there has to be a price reimbursement negotiation ongoing with the payers. This can happen in parallel. But ultimately, it's about a year-long process from the time of announcement of the data until drug is actually in the potential hands of the patient. So let me give you my perspective on non-cirrhotic NASH as far as potential for drugs. We have, as previously mentioned, 4 drugs currently enrolling phase 3 and 2 drugs where we have paired liver biopsy results from phase 2b. Those are Poxel's drug, which is a deuterated compound that is meant to function like pioglitazone, but without the side effects of pioglitazone. And then efruxifermin, which is an injectable FGF21. Look at safety and tolerability first. From the literature and from the presentations, it appears that all of these have mild to moderate adverse events. When we look at those that are probably the mildest, it would probably be resmetirom, and this is again my opinion, and then PXL065. The injectables, you see semaglutide and efruxifermin here, all carry GI side effects with them that are mitigated to some degree by starting the dose low and titrating upward slowly. Now, when we look at efficacy, I want to highlight 2 histopathologic endpoints: fibrosis benefit and NASH resolution. And also, I want us to look at insulin sensitivity and atherogenic lipids, because we can't just treat the liver in isolation. We need to treat the patient. And these patients have diabetes, obesity, atherogenic lipids, and they die of cardiovascular death more commonly than they do from a liver-related death. So how well did these drugs stack up not just on the liver endpoints, but on some of these others. And I highlight resmetirom here. Again, from the phase 2 trial, it had atherogenic lipid benefit, and it worked on a secondary endpoint of NASH resolution. Now, didn't have a statistical benefit on fibrosis in the phase 2. We'll see what the phase 3 trial holds for us. Now, with obeticholic acid, there was benefit on fibrosis benefit, but no benefit on insulin sensitivity or lipids. And then when we look at lanifibranor, it tended to have benefits on all 4 of these parameters. So good news there. We'll see if that holds up in phase 3 and that weight doesn't become a concern. Semaglutide, good effects on insulin sensitivity and NASH resolution, but no effect in phase 2 on fibrosis or lipids, except for triglycerides. And then with PXL065, good impacts on insulin sensitivity. You would expect that because it's a pioglitazone-like compound, and some positive implications on fibrosis, which, as previously mentioned, is not what we've historically seen with pioglitazone. So we'll have to see what happens there as that drug moves forward. Efruxifermin is that injectable, and it's shown benefit in the phase 2 on all 4 of these parameters. So good news there. What about cirrhosis? Well, we have less data in cirrhosis. We have 4 drugs with some degree of data, and it looks like belapectin kind of wins out on the safety and tolerability front. This is a galectin-3 inhibitor. It's given by infusion. You see the IV bag there every 2 weeks. Now, when we look at extrahepatic benefits juxtaposed against histopathologic benefits, we see from the reverse trial, obeticholic acid did not have an impact. Semaglutide did not have an impact on histopathology in a small trial presented by Rohit Lumba at EASL this past year in London, but it did have some impacts extrahepatically, as I previously noted, in the non-cirrhotic camp. Efruxifermin, which is an FGF21 agonist, actually had, in a very small trial of 20 patients or so, treated for around 16 to 20 weeks, biopsy showed about a third of those patients actually regressed off a cirrhotic morphology platform to F3, and there was benefit on many extrahepatic side effects, or many extrahepatic comorbidities. Belapectin, this is interesting. It is the only drug being developed that looks at prevention of progression to something. So it's also the only trial that's currently in an adaptive phase 2b/3 trial. So based off its early phase 2 trial, there was some prevention of progression to varices. So that became the primary endpoint for the adaptive phase 2b/3 trial. But there is no extrahepatic benefit here. So in kind of wrapping this up, what are our potential targets for NASH treatments? Well, we want them to hit the liver, both NASH and fibrosis. We want to have positive impacts on lipotoxic fat. We want to induce weight loss. We want to improve atherogenic lipid profiles and glycemic control. So is there a single therapy that can do that? It's yet to be determined. We're hopeful, but we think there's an opportunity for combination therapy. Ideally, these combinations should be oral for the long term, or if they're injectable, we want to maybe use them as induction use until we can get the disease under control and transition them to oral therapy, or use it for intermittent use. We want it to be incredibly safe and well tolerated and have synergistic impacts on histopathology, extrahepatic metabolic profiles, and also enhance long-term outcomes. Well, the best way to illustrate this, I think, is by my good friend Mike Charlton and his slide he used at NASH-TAG a couple of years ago. This is the Jamaican 4x100 meter relay world record team, and you see Usain Bolt on the right there, who still holds the world record for the 100-meter dash. But all of these sprinters were world-class in their own right. They got along well with each other. They were synergistic, they had complementary strengths, and they also had similar endurance. So I think this is absolutely the way we want to develop drugs in combination. So where are we going from here? Well, we need to move toward precision medicine, ideally to attack fibrosis. Can we get there with something like CAR T therapy? There's a very interesting article published in Nature Medicine in 2020 looking at using CAR T therapy to target senescent stellate cells in an animal model. I encourage you to check that paper out because it was remarkable what it did to fibrosis. Gut microbia is another target, whether it's probiotics, fecal transplantation, or targeting sphingomyelin synthetase 1 or others. I think that's interesting. The genetic polymorphisms that you see listed here provide an interesting opportunity to target in combination therapy as well. And then our oligonucleotide therapies looking at either RNAi targets against HSC17 beta 13 or PNPLA3 or DGAT2. So with that, let me conclude my briefing. Thank you so much for letting me participate today. Happy to entertain any questions you might have.
Thank you, Stephen. Yes, Professor Harrison. That was a fantastic talk, and you have convinced me that the future is bright. Can I just ask you a question first? I guess that it seems like most of these studies are currently mostly addressing to the metabolic pathway, but not that many so far we can see in the inflammatory pathway and fibrotic pathway. Well, in your opinion, what are the barriers, and then are there any on the rise that even in animal models or clinical?
You know, early on, what I didn't show, I didn't have time today, is to show you the graveyard of drug development for NASH. Like with any drug development pathway, there are drugs that don't make it. And so far, there are 10 in the field of NASH. Unfortunately or fortunately, I've been involved with 9 out of those 10. And many of those early on targeted inflammatory pathways, mediating inflammatory targets. And what we learned is that there are a couple issues. First of all, we need to somehow understand if we're hitting our target. Is there a marker of target engagement for a particular anti-inflammatory compound in development for NASH? That's critical. Number two, we need to understand that in NASH, and probably with most liver diseases, that the lower down in the pathway that you hit for the understanding the pathophysiology of this disease, the more redundant these pathways become. We use stellate cells as an example. There's over 40 different ways you can activate a stellate cell. If you're blocking one particular pathway and not the 39 others, it's very unlikely you're going to have sustained stellate cell suppression. And probably the same holds true for inflammation. Having said that, there are some interesting drugs currently in development that target inflammatory pathways. The one that I would say I'm excited about is the structurally engineered fatty acid icosapentate that is completing a very large phase 2b paired liver biopsy trial with North Sea Therapeutics. And in their interim analysis published on data at 16 weeks, there was very nice reductions in liver chemistry tests, markers of fibrogenesis, PRO-C3 in particular, and as well as improvement in highly sensitive CRP. That was quite dramatic. So again, the devil's in the details. I think we need to see what the histopathology shows us. But what we've learned is targeting therapies higher up in the pathway of NASH pathogenesis gives us the best shot at being pleiotropic and targeting multiple different redundant pathways. So I think that's a great question, Matthew.
Thank you. Yeah, thanks for the clarification. I think there's a question from Professor Ramadori. His question is, does resmetirom reduce body weight?
Yeah, a good question. And the answer from the phase 2b trial and from the Maestro-NAFLD-1 trial is that it does not have an impact on body weight.
And here's another question. So what is about the Japanese diet?
I'm sorry, Matthew, I didn't understand.
Yeah, maybe I'll have Professor Ramadori to illustrate a little in detail. I just reading from the chat.
Before that, I asked 2 other questions. PRO-C3 is, you mean collagen 3, right?
Yeah, it's a variant of collagen 3. It's a cousin to P3NP, actually. Yes.
Okay. But what you measure is collagen synthesis, not deposition. So if you check the level, the serum level of that substance, you don't have an idea about collagen deposition. That means fibrosis. You study collagen production. Which,
yeah, collagen,
okay.
That's right. So
Okay.
ProC3 is a marker of fibrogenesis, of collagen formation.
Right.
Mhm.
Just a short question. Metformin, you didn't mention that, but it should work like GLP-1 or A, and and receptor antagonists. So it does reduce body weight, and maybe, and the further question would be, what's about appetite reducing drugs? No,
Yeah.
there are no studies about.
Yeah. So first question on metformin. Yeah, I love metformin. I use it as a hepatologist exactly the way that former professor mentioned in the J Hepatology 2022 paper. I use it in reducing the risk of liver cancer in the setting of underlying liver disease and fibrosis. And I would also advocate statins fit that role very nicely as well. So almost every one of my cirrhotic patients are on metformin and statin therapy to reduce the risk of hepatocellular carcinoma. However, in the setting of NASH, metformin does not work, has never been shown to work to improve underlying histopathology in this disease. So I can't advocate that as a drug developer in the field for that particular indication, despite the fact that most of our patients are on metformin because it's such a foundational drug in the setting of diabetes. As far as drugs that impact weight, there are a number of them that do not work. If you look at obesity, drug development, many drugs have gone to the graveyard, unfortunately. But what does appear to be beneficial in the setting of fatty liver are the GLP-1s, but more specifically, regulating the amount of GLP by combining with a GIP or a glucagon receptor agonist, or all three together. And I think that's the holy grail moving forward. If you're going to use an injectable GLP-1, I think we're going to see better data with combination therapy there with a GIP or a glucagon or both. So because I can dial down the GLP-1 and I can mitigate some of the tolerability issues by combinations with other agents. And then we haven't even talked about combining those with something like a resmetirom or a lanifibranor or something else. So I think there's optionalities here. The field is kind of wide open for combination therapy.
Thank you. Thank you.
Thank you. Thank you again, Stephen.
Thank you.